And it's time to move on to our next panel. I will share the screen the right way. There we go. So we're going to move on to our capstone panel, Making It Real, Changing the Trajectory for At-Risk Older Adults. And it's my pleasure to introduce our moderator for the panel, Maria Zamora, who became president and CEO of Center for Elders Independence in March of 2021. So recent, and yet we know you so well already. So Maria brings over 25 years of experience in the healthcare and insurance industries to her role at Center for Elders Independence. She has held executive management positions at a variety of not-for-profit organizations and has dedicated over a decade in service to elders by leading multiple organizations providing PACE, the Program of All-Inclusive Care for the Elderly. So welcome, Maria. Thank you for being our moderator for this panel, and I will hand the floor to you.
Wonderful. Thank you so much, Wendy. Thank you all not only for being here today, but persevering and staying with us. I think this is going to be a wonderful final panel for the day. So this morning we've explored some programs and initiatives that can be part of the solution to rewrite the script that leads older people to unnecessary institutionalization. Now we want to welcome in some thought partners, each representing different entities that serve older adults, to explore the potential for building a system to best meet the needs of those they serve and many who may not be served today. Their full bios can be found in the conference program, so I'll just introduce them briefly before we get started. Jennifer Stephens-Pierre is the director of the Alameda County Area Agency on Aging. Jennifer Martinez is the principal at Wellbrook Partners. Dr. James Mittelberger is the Chief Medical Officer at the Center for Elders Independence. Kathryn Stambaugh, Geriatric Services Director at Lifelong Medical Care. And Kadin Caines, Regional Strategic Implementation Manager at Kaiser Permanente. So we've asked each of the speakers to bring their unique perspectives to the following two questions. How might we move toward a system that helps older people get the support they need in order to avoid unnecessary institutionalization, whether they are eligible for Medi-Cal or not? What might the challenges be, and what are the opportunities and next steps? I want to remind everyone to please share your Q&A, your questions in the chat. If we don't have time to get to them today, we will follow up with answers, but hopefully we'll have some time at the end for questions. And I'm going to start off by handing the floor to Kadin. Kadin, Kaiser Permanente is a huge delivery system. What is Kaiser seeing are the needs and challenges of its older adult members?
Sure, thank you. Can everyone hear me okay? Okay.
We can.
So I just want to contextualize it for Kaiser, for folks that don't necessarily understand the nuances there with Kaiser. So on our delivery system side, which typically, when I say that, I'm thinking of, through our EDs, through our hospitals, we see all flavors of housing situational disconnections, right? So what we see there, unfortunately, we see folks who don't have housing, folks who, own a home, are in a stable situation. I think what to us, what really challenges everything is that the system is not connected, right? So there's a lot of fragmentation, there's a lot of gaps. I think, Kaiser really tries to help our patients, right? Speaking of our patients first, to get them well, get them discharged, whether they are a Kaiser member or they're a member of another health plan. I think, unfortunately, where things fall short there is due to the fragmentation, it's really hard to sort of pass that baton on to that next organization and say, hey, here's what we identify, here's what we would suggest gets done, here's who we would use as a, skilled nursing facility or what have you. So I think that's part of the challenge there. I think when you talk about our members, and I believe Roland might have covered this in an earlier session, with our members, we have a bit more comfort there. We feel like we can offer them options, right, with our care team. So looking at our doctors, our nurses, our social workers, we offer them solutions. Hey, would you like to go home and receive home health care as opposed to being institutionalized? And again, the patient and their caregivers would make that decision. Hey, yes, we're going to go this direction versus the other direction. I think that for us in particular, where we have really tried to grow is we now have a program called like Advanced Care at Home. And what we do there is we're really trying to deliver care in the home as opposed to in an institution. Again, that doesn't suit everyone, right? And in some cases, members would prefer to go to an institution simply because their home may not be configured in a manner, or for whatever reason, their home might not be safe for them to return to. So typically, what we do there is we really try to have this be driven by what the patient wants, right? And I think that's a start, because really we should be working with the patient to determine what happens next, not saying to the patient, hey, you must go here because we know you can get the right care here, and we're unable to deliver the same kind of care in another setting. I think where Kaiser's challenged when you look at internally our members, and I'm speaking specifically about Medi-Cal, our current situation now, we are a Medi-Cal subcontractor in Alameda County. So we coordinate with, we ultimately coordinate with Alameda Alliance for Health to deliver Medi-Cal care. And in that space, generally, we're deferring to the health plan, right? They're ultimately telling us, hey, these are the contracts we have. Here's how we go about connecting those folks to services. And in those instances with the elderly, we only really control the Medicare piece, right? The Medi-Cal piece, or the folks that are Medi-Medi, it would be ideal if we could coordinate that. And in our current state, we cannot. So again, that will change next year, but currently we cannot. I hope that gives you a good flavor of the different challenges we face.
That does indeed, and thank you for providing that perspective. So we're going to turn to Kathryn now, and you are definitely coming from a different perspective as a federally qualified community health center that serves a significant number of older adults. What are you doing to support seniors to age in place? And what challenges do you experience, and how can we do better? And I think you may have some slides, I'm not sure.
Yeah. Great, thank you. So this slide is just here so that everyone can contact me later. So let's move on to the next slide. Okay, so let's just start by saying just a little bit about Lifelong. So we're a federally qualified health center that started as a geriatric clinic in 1976. And now we serve all ages across multiple sites, including about 6,000 seniors in Alameda County. And part of being a federally qualified health center is that we serve people who have really, really limited resources. So, for example, 91% of the people who come to us for care live at or below 200% of the federal poverty limit. Next slide, please. So mainly our role as a community health center is to provide medical, dental, and behavioral health care. We have a care transitions program, a care at home program, and a lot of case management through a variety of programs. So not nearly enough, which I'll talk about in a minute. Next slide, please. Okay, so I wanted to go into a little more detail in sharing some of the roadblocks that we face in serving seniors with long-term care needs in the community. Now, one case manager, she recently told me that her job feels like drinking from a fire hose because of the barriers she faces and just the level of need in the community. And another case manager said that there are 200 more people that she could be working with if she only had the time. So, you know, our teams they're working hard and they're doing great, but you know, they need more support. So some of the key roadblocks that we're facing is inadequate support for patients to help them follow through with what are often very complicated medical recommendations, a lack of coverage for needed services, so things like transportation, equipment, support for caregivers, adult daycare, adult day health care for folks who don't have Medi-Cal, et cetera. Highly inadequate memory care options or affordable memory care options, especially lack of affordable day programs in assisted living, and services that just take too long to get or are really hard to get. And this includes, you know, really important services like in-home supportive services and getting durable medical equipment, getting home health out to our patients, wound care support, the home and community-based alternatives waiver. These take a long time, you know, and other critical programs, you know, including Meals on Wheels has a wait list right now in Oakland. So it's really difficult to set up the sort of infrastructure that folks need. And then, you know, I always have to mention housing because, I mean, this is just like the big thing facing everybody, right? Like the lack of accessible, affordable housing, especially housing that includes services that people need, like permanent supportive housing and assisted living. And, you know, we have a lot of people who come to us for care who have a place to live, but it's not accessible. And that can make it unsafe and it can contribute to isolation. You know, someone talked about, you know, imagine a frail older person bedbound living up a huge flight of stairs, you know, that sort of scenario. Next slide, please. So there are some bright spots. You know, our case managers and community health workers on our care teams, they really increase access to resources and the ability to follow through with medical recommendations. So we are so grateful for them and their work. And our Care at Home program is pretty remarkable because we're able to provide primary care in the home to about 150 people annually. And then I also just want to call out some close collaborations that we have with community resources. And I've just listed a few of them here, but these are great partners and these referrals work really well because our staff have made personal connections. So they know who to call, they know what's covered, they know the eligibility criteria, they know whether they have a wait list. And so we really appreciate these collaborations. Next slide, please. So I asked some of my colleagues, what would make your job easier? So I asked this of some of our medical clinicians, our providers, and some case managers. And so here's some of the things they said. So they said a case manager for every patient at Lifelong who's 65 and over, better communication and resource sharing within sort of between county, the different resources in the county, and uniform referral systems, quicker response times from health plans and verbal authorizations, better collaboration with discharge planners, really thinking about hospital discharge planners there, and then just adequate services, you know, transportation that you can easily order that actually shows up and takes you where you need to go. Like it's not assured. We have people who've missed specialty appointments that took months to set up because the transportation that had been ordered and confirmed never showed up. Like this is not acceptable. We need in-home supportive services with adequate hours and staff. You know, people need to have access to healthy food and again, affordable and accessible housing options. Always, always housing. Next slide, please. So some practical suggestions. So first, we need more case managers for people who need and want that support. So I think we need to really maximize this ECM benefit and make ECM feasible and sustainable for the FQHCs and CBOs to offer. We need to attract more people to the workforce. We need to pay a living wage for direct care jobs. We need more student programs and internships and part-time jobs working with seniors, you know, to introduce people to our sector. And we need more paid internships for MSW students, so it is not such a financial hardship to get into social work. We also need to streamline referrals and resource sharing so that it's not so difficult to get folks into the services that they need. So really fully develop and maintain an up-to-date, easily accessible resource directory. Next slide, please. And then, we need to continue to advocate for more housing, for more affordable assisted living options, for better transportation, for more affordable supports outside of Medi-Cal, for financial stability for service providers and staff. And honestly, we have a real problem with funding that doesn't cover the costs of providing services. And we have some payers who don't pay on time, and community organizations cannot float big payers for 6 months or a year. Like, that is just not sustainable. And, lastly, I just wanted to acknowledge sort of everyone in the Zoom room here, like that we need to take care of ourselves and each other, because this work is so rewarding and it's also really stressful. And I just want to say that I appreciate all of you, and I hope we can all take some time to just be kind to ourselves. Thank you.
Thank you so much, Kathryn, and for so beautifully highlighting, where there's so much great work to be done, but a lot of work yet to be done. So I'm going to turn now to Dr. Mittelberger. And Dr. Mittelberger, today you're here representing a PACE organization, but I think you bring such a unique perspective based on your many years of experience in various care settings, focused primarily on serving older adults. And I think it would really help us for you to help to lay out how we might best address the needs of older adults outside an institutional setting and thinking about what matters most to those individuals.
Thanks, Maria. Yeah, I just wanted to make a shout out to my fellow speakers and to the people in this committee. I'm quite moved by the sense that we need to work together. It's going to take all of us. There's probably no one solution that's going to be for everybody. I started at Lifelong in 1986 as a medical director. I believe that program is amazing. I was really honored to be, I was at Highland and started their geriatric program I was there for about 20 years, and I was really pleased to be a founding board member for the Alliance. So it's really exciting to see all of us actually coming with CalAIM and other endeavors, really having potential to make a real meaningful difference. I'll take the first slide. So I wanted to just take a moment, it's just a picture, but just ask ourselves, what is real equity? As frontline providers, what does it really mean? And I'll tell you what we talk about. We talk about what we would want for ourselves or our loved ones. What kind of comprehensive care would we really want? And when you look at a program, you say, is this really what would work? And so we start with that in PACE. I think we should all start with that. And that really makes your care person-centered and focus on what they need. And then you have to ask, are we also delivering that care to diverse populations? At CEI, we have over 50% of our patients don't speak English. We have to deliver care in culturally competent ways. We have a large number of African American and a diverse group of populations. So we want to deliver care that's the same quality we would want to people from different populations that have been underserved and haven't received a fair shake for a long time. That's the vision. And I hope that's what we try to do in PACE every day. Next slide. The thing that is unique about PACE, I believe, is the comprehensive commitment to really meet our participants, and we call them participants. They are participants who direct the care where they are and give them what they need. And we are not just case managing and putting things together. We are responsible for the full array of care that these complex people need. I could go through this list, but we have to deliver each and every one of these complex services. And we bring a team of truly specialized geriatric physicians, nurse practitioners, social workers, rehab staff, and we put together a model of care. And day in, day out, there is no excuses for us. The transportation has to be there. The medical care has to be there. We are responsible. That is a unique, I think, structure for PACE. And I do think we should hold ourselves in whatever system we're working to owning the outcome. What actually happened for this person? Was this care what we would have wanted? So that is what PACE is able to do with its all-encompassing care model. And that is really what I hope all of us are trying to achieve across our different healthcare systems. So I'll end with another slide. This is kind of what we're trying to create in PACE. First of all, let's look at the picture on the right. I'd love to have it even be more diverse. This is all the best I could put off the internet though, but we've all been to some really good potlucks. Potlucks are where we're delivering much of the care in Caines, and I hope we can continue to do it. We shouldn't stop. But you know, for frail seniors, they need to make sure they have a truly organized, balanced, and comprehensive program. And sometimes at potlucks, nobody brought salad or nobody brought an essential ingredient. So what we strive to do in PACE is to bring a diverse, really healthy and complete set of services, or let's say a meal, to our participants every day. So we are able, in terms of answering the question of how can we help people stay away from institutionalized settings, we are able to take a group of participants, very diverse, 100% of whom qualify for long-term care, and currently have 3 to 4% of them in long-term skilled nursing facilities by providing the other services. And I look forward to working with all of you to continue to find ways to keep more people in our community connected to their own lives and health. Thank you.
Thank you so much, Dr. Mittelberger. And I'm going to turn now to Jennifer Martinez. Jennifer, what is the Social Health Information Exchange? And how do you see it playing a role in quality population health work?
Great, thanks, Maria. Hi all, I'm Jennifer Martinez. I'm speaking here on behalf of Healthcare Services Agency and about the Social Health Information Exchange that was stood up as a part of the Whole Person Care effort, where I was the Program Development Director for 6 years. But really that Social Health Information Exchange has really grown and expanded well beyond that whole person care space where we started. So I want to talk through what that looks like, so we can all be thinking together about how this can be a tool to affect these kinds of changes that we're discussing today. So I'll go to the next slide. And actually can go to the next one. Thank you. So the Social Health Information Exchange, or the SHE as we call it, that is housed within Healthcare Services Agency, was really looking to more effectively and systematically bring together all of these different sectors that we've been noting today, to where a particular individual might be already touching many of these systems, but there's not really the regular routinized way for both providers to know about each other's work, and to even know that they might actually be on the same care team across sectors, that they just might not be aware of it yet. So looking to really bring data together in a more consistent way to both identify needs at a population level and also to equip providers for the kind of care coordination, care management that they're doing to address someone's whole person care needs. So we can go to the next slide. So for what this infrastructure actually looks like, we are now up to 19 data feeds from across sectors that come into the Social Health Information Exchange. And all of those data feeds are kind of supported and structured according to our data sharing agreement that is really specific about how that data is stewarded, how it can and can't be used, what the expectations are for both the data provider and for Healthcare Services Agency as the steward. And then many privacy and security structures that are really baked into the infrastructure to ensure that only the right data is made available to the right individuals in the right circumstances about the right consumers. And then a lot of really detailed record matching. You know, if we just stayed only in the clinical space, then the record matching is not error-free, but is a little bit easier. Once we really get into what we might categorize as the social areas, some of the more non-standard data feeds that we'll talk about in a minute, that matching is really important and can be more challenging. So we have both automated and kind of human looks at the data to make sure that where I'm Jennifer Martinez or Jenny Martinez or J Mart, depending on the data feed, that the right records are fused together to help providers and organizations understand what my holistic needs are. So we have that sort of as the foundations, as the platform for the Social Health Information Exchange, and then we leverage that in a few different ways. One we kind of call is general data exchange services. So we actually send data back and forth with our managed care plans to support CalAIM billing, and also to provide the managed care plans information about their membership that they might not already know from all of the claims and services that are brought to them. So information that's coming from other systems that they need to know to really effectively identify folks that are eligible for these services and to help do the right linkages and provide that kind of at a population level. And then analytics, again, looking at these populations, developing the useful tools that are in reports or dashboard type structures to allow for looks at equity, and also making sure that the right subpopulations are getting connected to the right services. And then we have a whole category of applications, again, some around CalAIM billing, kind of giving the right front door so that organizations can make sure that all the financial reconciliation is done effectively within the agency for CalAIM billing. And then our community health record. Our community health record is a kind of a client level look across all of these different data feeds for a care coordinator or care manager to understand where is this person already receiving services, who are they connected with. It provides alerts, real-time alerts around hospitalization or ED visits, and helps to kind of facilitate those connections between other providers that they might not already know are working with that client. And then we have an additional application that's supporting our behavioral health providers that are working at Santa Rita Jail. So let's go to the next slide to just give a little more granularity. These are the kind of the spread of data feeds that are coming into the Social Health Information Exchange today. A fair amount of sources around acute and emergency care, as well as other medical sources. And then we do integrate information from the county's behavioral health system, as well as a couple of behavioral health providers in particular. And then we do bring in homeless and housing information from the Homeless Management Information System, HMIS, have some public benefit information from our county's social services agency, and then information about who is in jail and been released from jail, as well as insurance coverage. So there, you know, in many other parts of the state, there are lots of health information exchange organizations out there, and most of them do focus in the clinical space, and there might be some social pieces where providers have the time and energy and ability to document, you know, diagnosis codes related to social needs. We wanted to make sure that we kind of lifted up the heavy burden of bringing in some more of these social data feeds to flesh out the look and understanding of these individuals. And we have more to go. You know, this is where we started. There's more work to do to bring these data feeds together even more effectively to do the kind of population look that we're talking about today. And there's probably additional data feeds that could help to flesh out the information further as well. So I've mentioned a lot about the kind of the population level, the analytics work to identify subpopulations. I'll just say too that the community health record in particular, you know, it's not an electronic health record. It's not even necessarily a case management documentation platform per se, though there is some shared care planning space in there. But if we can go to the next slide, it's really a space for providers to find each other as resources and not have to then call 18 different clinics to figure out where a client is already being served, but where their providers can actually already find one another to do some of the care coordination to help keep folks out of institutionalization, make sure they're not doing redundant work, learn from one another, knowing who to contact, and saving that time and effort, we found can go a long way. So these are the organizations that we're working with on that tool today.
Thank you so much, Jennifer. You know, certainly information is power, and you know, to the extent that all of the wonderful organizations, not only on this slide, on this call today, but probably others, could have access to information, certainly we could probably make better and more informed decisions as we serve. So thank you so much for sharing that with us today. And I'm going to turn now to our next speaker, not only our next speaker, our next Jennifer Stephens-Pierre. What is the Aging and Disability Resource Center's role in connecting older people to services, including new medical services under CalAIM? And what are the barriers that you see that people face in getting the support they need when they need it?
Before you answer that, Jennifer, I wanted to, I see Richard has his hand up, and I want to remind Richard that we're taking the questions in the chat. Thanks.
You're on mute, Jennifer.
Thank you for the opportunity to present today, Maria. I really appreciate it. You know, before I start my presentation, the ADRC is a relatively new concept in Alameda County, but listening to the advantage of being one of the last speakers is that I had an opportunity to listen to everyone speak and to be able to identify some of the overlaps, and hopefully I'll be able to tie those overlaps in the ADRC. And the common theme was coordination, collaboration, navigation, a lot of discussions about care transitions and home modifications and housing, caregiver respite, case management, and just the no wrong door, which kind of segue us into what is the ADRC and how does it fit into the system and how can it help with some of the barriers and some of the challenges that older adults encounter in entering long-term service supports. And so I just really appreciate this opportunity to highlight this program. You know, the state, back in 2019, there was a bill that passed that gave funding for counties to build out an ADRC. Alameda County applied for that funding, and we were selected as an emerging ADRC, which really gave us a chance to build out a no wrong door system of delivery in Alameda County. And to really kind of take a look at what that means and what it looked and what does it take to make that happen. What we're really glad to announce is that we were designated in 2019, and we were appointed as a designated ADRC in December of 2022. So we're really excited about that. I am one of the executive partners for the ADRC, along with my two independent living centers, or the county's two living independent centers, the Krill and the Seal, and I think Michael Gavin is on the call. He's also one of the executive partners that is a part of this. And I see several of our advisory council members. So thank you for also participating in this today. But just to give an overview of how this is connected, is that the vision of the ADRC is that every community in Alameda County has a highly visible and reliable universal access point that provides information and facilitates equitable access to long-term service supports for all residents in Alameda County. That includes older adults, people with disabilities, caregivers, and families. To achieve this, what the state required is that there was a collaboration between between AAAs and our two local ILCs, which is the Krill and the Seal. And that is the collaboration that exists right now, with the plan to extend this collaboration out to all of our community partners. The way that we perform these services is through you. Most of the people who are on this call right now are the services that we utilize in order to create this no wrong door service. The ADRC provides access to a full range of long-term services supports, provide objective and unbiased information, advice, counseling, and assistance. No wrong door assists individuals of any age, disability, income level in navigating the complex system of long-term services support. Next slide. That service is done in, that type of coordination is done under 4 core services. And these services will sound familiar to all of you because it is something that, as you look at the slides and the programs that have presented today, some of these services are very similar. There's a lot of overlap. And there are a lot of situations where I hear the story about Joe and Barbara that APS presented, that a lot of those clients, we share a lot of them. And through enhanced information and assistance, that's our first category. And enhanced information and assistance is a consumer-focused approach to interactions. It's person-centered. Program staff are trained to actively listen to the consumer, with their participation, triage and assess, educate consumers, call us about available services, often dependent on the need, or the immediacy of the need. The consumers provided referrals to information and services. Consumers that require additional assistance beyond traditional referrals are warmly transferred to service providers. Another category is options counseling. The options counseling is an interactive process where trained option counselors with rich knowledge in long-term support services meet with consumers to discuss individual long-term service support goals, provide assistance around decision-making, information about resources available, and to help with an action plan to meet those goals. The options counseling will later follow up with the consumer to ensure that the action plan remains relevant and on track. Another piece is short-term service coordination, and I think that this is where we work a lot with our community partners in making sure that we can help consumers navigate through the system. This is where we really assess if a person really needs this level of intervention from us. A lot of our calls come from people who may not know that there are other services available to them. For our older adults specifically, what we find is that when we're on the call with them and we're trying to figure out the best way to help them navigate the resources and the options that we've given to them, they may have some difficulties due to like cognitive issues, mobility issues to be able to access those services, not really knowing if they're eligible for those services. And this is where our like hidden middle class, older adults who really have historically not been eligible for services, this is where this program is very helpful. But the short-term service coordination basically bridges a gap in connecting consumers or callers that urgently need one or more multiple services with formal and informal long-term services support to prevent unnecessary admissions to nursing facilities and or hospitals without intervention. So one of the, it really connects one of those common themes that has been discussed on this call, which is preventing institutionalization. And we find that short-term service coordination is a really great way to do that. It's one thing to give information, one thing to give options, another thing to connect and do those warm transfers and really make sure that that person connects with the services that are being offered. And then last and not least is the Care Transitions Program, which, East Bay Innovations, I heard that you provide this. I think that this is very similar to what's being provided with CalAIM in your ECM programs, but is the Care Transitions. And basically what that is that we assist and support transitions of individuals living in long-term care facilities back to the community and directly address any barriers in order to facilitate that transition back home. Things like working with discharge planners in hospitals and skilled nursing facilities, advocacy, common theme, durable medical equipment, assistive technology, case management, home modification, and in some places also assisting with securing housing. And so those are our 4 core services, what we like to call care coordination.
Thank you so much. And I'm gonna stay with you for just a moment, Jennifer. And the ADRC is working to connect people to the services that they need, whatever their health insurance coverage or level of need. So it really has tremendous potential to go upstream to prevent crises and unnecessary admissions to hospital and SNF. You mentioned, I think, some as you spoke, but what do you see as the opportunities for partnership? So you may just expand on a little bit on what some of the areas that you talked about, or talk to us a little bit about additional areas for partnership.
There are, when you listen to the different presenters and what has already been put out, we're all working together and we're doing it. And I think that one of the ways that we can really begin to do that more is with making sure that we have those voices at the table. When we're having different forums, being at the table, making sure we are representing all of the populations that we see that need need the most help. People who are Medi-Cal eligible, people who are not Medi-Cal eligible. So that is one of my biggest things. Also, in making sure that we know what our services are. It's one thing to have a resource available. Another thing to be able to talk or know enough about that resource to refer someone over. Really great resources with Alameda Alliance, really great what you're doing. And I think that this forums like this, so Senior Service Coalition thumbs up to this type of forum where you're bringing these providers, all the providers together to share this kind of information so that we all kind of know that we're doing these things, but sometimes we're doing them in silos. And so the silos is one of our biggest barriers in making sure that clients have that continuity of care, that continuity of services. And even in your presentation about SHE, one of the things that you said is that multiple people touch this case. Multiple people. And how do we know? And that's one of the great things about the SHE is that it is pulling this information from these different providers. So consumers are not having to start over with asking for help. And I think that is one of the ways that we can partner together, when we're developing a system, when we're, right now we're in the process of building out a website, making sure that we're getting that feedback from the different consumers and the providers on this call, and one, to make sure we're not replicating efforts, but if there is opportunities for us to connect. And I think that this is a really great point in time for us to connect with our managed care systems, for us to connect with our other providers, some of these common names providers that we already share, Life Elder Care, Daybreak. I'm looking at the different cities. I'm looking at 211 on the call. These are services that we, Allison, hi. But these are services that we already utilize, but just figuring out a way to make these services universal and connected and coordinated, and that we can easily navigate consumers through these services.
All great points and great suggestions. We certainly could extend our reach that way, reach program. So Kathryn, I want to come back to you and ask you to just deepen a little bit and talk a little bit more about the challenges or roadblocks to getting people the supports that they need to live in the community.
Yeah, for sure. So I talked about this a little bit, so I'll expand more. There are the big systemic challenges, and then there are the day-to-day challenges. And I think it's important to acknowledge both. So, all morning we've been talking about equity, and the context that we live in still reflects our long history of social injustice and violence towards people of color, and racism, classism, sexism, ageism, ableism, homophobia, like all these things have been working against people for generations, and they're part of an economic system that allows some people to get very rich or at least stable, while other people barely get by and live in neighborhoods with bad air and not enough grocery stores and literally shorter lifespans. So as a result, a lot of seniors have no savings, have not accumulated generational wealth, and have health issues that are exacerbated by stress and poor diet and like all the things that are made worse by poverty and discrimination. And we have a social safety net that's not yet really comprehensive or truly person-centered, even though a lot of great work is being done and we're breaking down silos and we're seeing all this progress, and we've heard about great progress today, but we're just not fully there yet. So that's kind of like the big picture challenge. I want to say what feels a little different now. Well, first is that housing is just so expensive. And a lot of key services right now are not readily available. And so many places have major staffing and funding challenges. And so we're seeing long wait lists and restrictive eligibility criteria. So, as I mentioned before, it's really hard to set up the infrastructure that's necessary to support people with long-term care needs to live at home. So I'm talking about home health, transportation, food programs like Meals on Wheels and Project Open Hand, in-home programs like IHSS and HCBA, and services for people with memory loss. Like there's so many services are stretched so thin, and housing is just starting to feel almost impossible. So I think that's like the day-to-day challenge. Number one is just not enough of the key resources to meet the level of community need. And then challenge number 2, in terms of sort of day-to-day challenges, I would say, our services are still fragmented and tied to specific pots of money or geographic regions. So it is hard to keep track of eligibility criteria and to know, who still has funding and what part of the county do they serve and do they have a wait list. So, consumers really need experienced navigators, like to figure out what they might actually qualify for. Do they want that? What are the pros and cons of accepting different services? And then if they want